So what I'm going to be talking about is that really all anterior segment surgery, all of the surgeries that we're performing are refractive surgeries. I have no financial disclosures. So we kind of have to ask ourselves, really, what do we define as refractive surgery at this point in time? And I think really the definition should be any surgery that we do that changes the refraction of the eye. But have patients really made any surgery that we do into a surgery that's supposed to have a positive refractive outcome? So it's supposed to improve upon the refractive error of the eye. But when you just hear refractive surgery, we really start to think about laser refractive surgery. And so just to go through a little bit of the history of laser refractive surgery, it really started with the excimer laser. And so excimer, it comes from the excited dimer that's created by the laser to create photoablation. And again, these lasers were first used in order to actually etch computer chips. So they're very precise. They remove just a few microns of tissue. The amount of energy that is dissipated there does not cause a whole lot of thermal heat. So there's very little damage to the tissue next to it, which allows us to kind of change the shape of the cornea. I don't know why the color is kind of off here.
Try to see what I can do for you.
Okay, so with PRK, PRK is kind of the first of the procedures that came into vogue. In order to do PRK, we know that we need to remove the epithelium, and of course there's a number of different ways for us to be able to do that, and we're treating starting at Bowman's membrane using just the excimer laser itself. So PRK, of course, has significant pain afterwards due to the epithelial defect that's there. So it was pretty rapidly declined in popularity after LASIK was developed. However, PRK remains better for patients who have epithelial basement membrane dystrophies, if they had aborted LASIK or had flap complications from a LASIK procedure, and patients who are status post-keratoplasty, or if they've had radial keratotomy surgery. There is some thought as well that PRK patients may have a little bit less dry eye than the LASIK counterparts. There is the risk of corneal haze that can develop with PRK, as we heard about a little bit earlier, and of course the use of mitomycin C has decreased that risk dramatically, kind of expanding the range of refractive errors that PRK can be used for. Now, I always got confused when I would see advertisements or comments about what LASIK or epi-LASIK are, and really they're kind of forms of PRK where they're trying to preserve the epithelium. So in LASIK, you're using alcohol in order to loosen the epithelium. You try to keep the epithelium as a continuous sheet that you slide off of the eye for the excimer ablation and then slide back over. In epi-LASIK, you're actually using a microkeratome set to a very fine thickness in order to just remove the epithelium and kind of use that as a flap, again, removing it during the ablation and then placing it back down. However, the studies have shown that neither one of these are superior to PRK. One of the recent developments that I wanted to kind of let you know about is this idea of using the EpiClear epikeratome. So this is another way to remove the epithelium. It's kind of more, less traumatic, and so studies have shown that for patients there's less pain and there's faster healing. And so this is a really good option when we need to remove the epithelium for patients who are undergoing corneal collagen cross-linking. So the device itself has a little handle, and at the end of the handle here is the part that removes the epithelium. This is all really made out of plastic. There isn't really a blade on it. And what it does is it bunches up the epithelium, and as you brush multiple times, you're actually removing the epithelial cells kind of layer by layer. And so you can see in the animation here, it bunches and then collects the epithelial cells. You go back, you make another pass. Again, you're collecting more of the epithelial cells. you're getting down to the base of the epithelium and you're able to remove those cells. But once you get down to Bowman's membrane and there's no cells there, it doesn't remove anything, it doesn't make any chatter lines that you may get if you're using a sharp instrument, and you can keep brushing that as many times as you want without causing any problems. And again, because you're leaving that membrane intact, people are able to heal that epithelial defect much faster. So LASIK, of course, kind of came on the scene, and keratomileusis, meaning, of course, to carve the cornea. This combines creating the flap with the excimer ablation. And the big development there was in creating the flaps using the femtosecond laser in replacement of the microkeratome, which has made it more precise, more reproducible, with a more consistent thickness. So new on the scene to the laser refractive surgeries, and again, I don't know why this is formatted so strangely, I apologize. Myopia can be treated up to -10 with the new SMILE procedure, which stands for small incision lenticular extraction. It is in Europe being used for astigmatism up to 6 diopters, and it's undergoing FDA studies right now. And again, we'll talk in a little bit about some publications coming out comparing SMILE to LASIK. So what we see here is, if we can have the lights down again, actually, because with we see these kind of multiple cuts, and I'm going to show you in the video here. This is only using the femtosecond laser, and so it creates a posterior lamellar cut, and then it creates an anterior lamellar cut in order to create this lenticular shape. The femtosecond laser is then used to make a small incision on the surface, and then you actually have to go in and dissect this kind of cap out. The animation, of course, makes it look like it's the simplest thing that's ever been done by just pulling it straight out. But if you've ever seen any of the videos of the actual surgery, you know that it's not that simple. So again, when we think about refractive surgery, are we saying that only laser refractive surgeries are refractive surgery? Well, if that was the case, my talk would end right now. So obviously, I'm saying that the answer is no. And we're going to take small steps. So the first step that we're going to say is that cataract surgery is refractive surgery. And I think the buzzwords for a long time has been saying refractive cataract surgery. You know, you can go to ASCRS and to the Academy meetings, and they have whole symposiums just about refractive cataract surgery. But patient expectations have taken every cataract surgery you do, regardless of what technology you're using, and they expect a perfect refractive outcome. So what do we have in our armamentarium here in order to treat these patients? Well, the first is that we have lens-based treatments. We have monofocal IOLs. They even themselves have different amounts of negative spherical aberration. So if you have a wavefront aberrometer in your office, you can take measurements of each individual patient and then tailor even the monofocal lens that you're going to be using for them. Of course, the development of toric intraocular lenses improved on our ability to treat astigmatism at the time of cataract surgery, adding to the ability to use limbal relaxing incisions or subsequent laser refractive surgery. Multifocal and accommodative intraocular lenses to try to give extended range of focus for patients. Again, the majority of these still today are relying on a diffractive technology, and this is certainly somewhere where we're all interested in advancements that will give some better benefits to the patients. Oh, and this is really unfortunate. Is there any way to change?
Unfortunately not. It's an in-house projector issue, nothing to do with the presentation.
Okay, so I wish I could lift this tiny little screen and show you, but this is basically a representation, so from a patient's blog. So this was a patient out of the UK, and he actually had 2 different types of diffractive multifocal lenses. He had a Restore placed in his left eye, and he had a Symphony lens placed in the right eye, and he had a relative who is a graphic designer. So he actually described to his relative his exact symptoms of the glare and starbursts and spider webbing that he was having. So actually on this image, which isn't showing up because of the contrast that we're getting, we see the actual rays of the lights, and then there's actually one image of it, those two combined. And so if you want to show this to your patients, the link, if you just look up intraocular lens experience on Google and look for the WordPress blog, these are really, really nice images that aren't showing here, that are really good to kind of show your patients when you are counseling them about the advantages and disadvantages to the multifocal lenses. Again, when we think about cataract surgery as refractive surgery, we're also operating on the cornea. So even the location of where you're placing your main incision has an impact on the patient's postoperative astigmatism. So you want to try to operate, if you can, on the steep axis, and even that may get them 0.3 diopters of reduction of astigmatism. And of course, we have the ability to do LRIs. I think what's really going to advance cataract surgery going forward are the continued use of our guidance systems, the Varion, the Aura, also using our own data in order to be able to create a specific surgeon factor, and new formulas that are coming out, especially for post-refractive, laser refractive surgeries, and also the swept biometry as well. So taking a smaller step on this idea of all anterior segment surgery as refractive surgery is the idea of doing a superficial keratectomy. So a lot of times we think of superficial keratectomy as just a way to normalize the ocular surface in order to get better biometry measurements. But really, we're also trying to clear the visual axis. So if you have a Salzmann's nodule that's sitting right in front of the pupil, removing that is going to have a significant improvement in the patient's vision. These we do also for band keratopathy with EDTA chelation and for epithelial basement membrane dystrophy. So this is a patient who was referred to me who had Salzmann's nodules in both eyes. And again, you can see this pretty significant irregular astigmatism that the patient had in each eye with visions of about 20/50. And so she was thinking that she was going to need superficial keratectomy and then progress on to cataract surgery. But after we did her superficial keratectomy, we actually saw significant normalization, not quite all the way, but much better than where she was, to the point where we see the astigmatism reduce from 6.3 diopters all the way down to 1.4, and from 5.3 down to 0.7. So that took her vision from 20/40 down to 20/30, and from 20/50 down to 20/30. So the patient was actually very happy with this level of correction, and still, it's been about 2.5 years, has not required cataract surgery because of the improvement that she's had in her vision. Now, I think it's important to remember when we do these surgeries, we think of superficial keratectomy as kind of being one of the smallest surgeries that we do, but again, you want to take the caution not to violate the deeper layers. In Salzmann's nodules especially, you can just peel those off of the ocular surface, leaving Bowman's membrane untouched. And I think by being cautious and doing that carefully, you can get better refractive results. So kind of along the same lines, pterygium surgery is a refractive surgery. It's also a cosmetic surgery. So here we see the pterygium intraop, we see the patient after they've healed postoperatively, and I stole these slides from Dr. Lee. There was a study that was done by Lawrence Hurst out of Australia. He actually has the largest collection of pterygium due to the hole in the ozone layer that's there. And he actually did a study grading for cosmesis, where they would have two eyes, one that had had surgery, one that had not had surgery, and was using the perfect technique that he describes, which is a very large conjunctival tenonectomy with a very large conjunctival autograft. And so interestingly enough, 40% of the viewers of these images actually preferred the eye that had surgery. But what about the refractive side of things? So again, we see a very large pterygium on the side here that is extending into the visual axis. We see the concomitant flattening of the cornea that coincides with that. And of course, after removing the pterygium, we see much more normalization, although not complete normalization. This is still in the fairly early postoperative period. So the expectation is with continued epithelial remodeling this will normalize even a little bit more from here. But the patient did have a reduction in their astigmatism from 11 diopters down to about 4.8 diopters. So what about some of the newer procedures? So things that are just coming on right now, well, those too are being looked at as refractive surgery. So we heard a little bit earlier about corneal collagen cross-linking. The goal right now really is to just stabilize the cornea. We don't want it to progress, but we are noticing that you get a reduction in the Kmax. So there is some flattening that holds for the long term, although right now it's not terribly predictable. So what is being worked on are these ideas of photorefractive intrastromal cross-linking, which has kind of been nicknamed pixel, where you are actually targeting certain degrees of myopia and hyperopia in order to get the desired flattening or steepening results, just like what we do when we're reshaping the cornea with the excimer laser. Right now, it's being used for just about a diopter in either direction of hyperopia or myopia. And I actually asked the a vitro rep outside, and it's probably still 4 or 5 years away before they think that it's going to become more commonplace. The others, the idea of doing cross-linking and then doing topography-guided PRK, or doing zonal or topography-guided cross-linking. So really only treating the ectatic portion of the cornea. Currently, we do a 9mm ring that just treats the entire central cornea. So we know that we're treating some parts of the cornea that are essentially normal while we're also treating the parts that are more ectatic. So anytime that we have new procedures that are coming out, I think it's important for us to keep in the back of our minds about what is going to happen in the long term. So I put the PERC study up here, which is the prospective evaluation of radial keratotomy that came out after 10 years. Because the initial results with RK were very beneficial, lots of patients had it. Then we saw that it was not stable, it continued to deteriorate, everyone had this hyperopic shift, and it was pretty much abandoned. So I think anytime that we see these, we want to make sure that they really are as good as they're saying that they are. And one of the hot topics, again, is this idea of PRK combined with cross-linking. And since cross-linking is something that's new to us, it's not new to the rest of the world. And so there are some countries that have already done topography-guided PRK with cross-linking. And some of them have actually abandoned the procedure because they found that they were having an unreasonable amount of post-treatment haze. And unlike the normal PRK haze, which is typically in the anterior cornea, they were finding that the haze was actually extending through all different layers of the cornea. One of the things that we're working on here at Doheny, this is actually a device that is developed by a South African ophthalmologist who approached us. And so this is a treatment that would be done at the time of cross-linking. This is an aspheric, rigid, hard lens that is not UV blocking, and so it's actually used as a mold at the time of the cross-linking procedure. So instead of just treating the patient's cornea the way that it's shaped naturally, what if we actually mold it and press it into a more desirable shape? And so we're going to conduct kind of a phase 1 study to see if it creates more reduction in the Kmax than the current treatments. And again, even older procedures that we have right now are going to have better refractive outcomes. So when we think about LASIK and PRK, we know that we've gone from kind of conventional treatments where we're just treating lower order aberrations, myopia, hyperopia, astigmatism, to now more customized treatments where we're actually treating the patient's own additional higher order aberrations, or we're at least optimizing our treatments to them. And this has also been shown to be pretty equal between the two. And our outcomes are very, very good. And this is the reason that most people think of laser refractive surgery first when we think about refractive surgery. And again, even these wavefront outcomes now are starting to be surpassed by topography-guided LASIK. And again, you know, we see that we can have 93% or better of patients achieving 20/20 vision, and even 70% being 20/16 or better, which is really remarkable. So it's important then that we're testing the new technologies that are coming out against these older technologies, not just always going for what we expect to be the newest and greatest, and actually comparing the current iteration of SMILE compared to topography-guided LASIK. The topography-guided LASIK comes out better both in the visual acuities, but it also came out better in which the patients performed as they were doing LASIK in one eye and SMILE in the other eye. Some thought for this is that LASIK actually employs a tracking device, tracking software in order to follow the eye during the treatments, whereas SMILE is very dependent upon how you dock the patient into the laser. So that is an area where there could be some improvement for the SMILE side. So in summary, refractive surgery is not just laser refractive surgery. I think it's important that we take refractive considerations into account for pretty much all of the surgeries that we do. So even the smallest, or what we think is the most inconsequential surgeries that we perform, can have significant refractive outcomes for the patients, both in the negative and the positive. And we want to make sure that we're doing everything we can to try to deliver those results. So those are the references. Thank you. And any questions?
There is a good algorithm on your lens selection based on the patient's pre-existing positive or negative collaborations post-LASIK. In your experience, how much quality effect does that have on the patient based upon your selection?
So the question is in relation to choosing an IOL based off of the positive or negative spherical aberration of the patient. So it's one of those things that I think is really difficult to measure because of course it's going to be a totally subjective result. But I think that you do find those patients have less of the secondary symptoms from the lenses. So even patients, we have them come into the office, they had a monofocal lens, you talk them out of getting a multifocal lens because you didn't want them to have glare and halos, but they still come back with a monofocal lens having those glare and halos. So I think paying attention to those little differences can reduce it a little bit. Again, no matter what you do, I think you can be as perfect as possible. There still will be some of those issues, but at least you know you're doing everything you can to give the patient an outcome that's not going to have too many higher order aberrations afterwards. Any other questions? Yeah.
I would almost argue that DMAC DSEC is a refractive procedure.
Mm-hmm.
Can I give you an example? I've had two patients who had quote-unquote mild flukes, who had multifocal IOLs placed by somebody else, and then the patient was really upset. But actually the cataract surgery looked perfect, and they didn't have edema, but they had goutte centrally. And because of the goutte plus the multifocal IOL, they were just really, really unhappy with that vision. That patient eventually had to have a DMAC and was really happy after the DMAC. The DMAC induces very little hyperopic shift compared to the DSEC. So in those two cases, I was forced to do DMAC as opposed to DSEC because I didn't want to affect the refractive error too much. The patient was so happy with that eye that they wanted me to do the other eye. And I felt like I didn't want to put a monofocal IOL in the other eye when the patient now has a multifocal in the other eye. So I also did a multifocal in the contralateral eye, telling the patient, you're going to have a DMAC also. So now these two patients are walking around with multifocal IOLs in both eyes and DMACs in both eyes and happy. But I don't think they would have needed to have a DMAC, honestly, to begin with, for non-ademptus flukes, or basically asymptomatic flukes, if they had not had a multifocal IOL to begin with.
And I mean, even the glaucoma procedures have refractive side effects too. When people suture down a trab, for instance, depending on how tight the sutures are placed, that can affect astigmatism. And there are some patients that have high amounts of astigmatism because of that are kind of challenging to treat because the contact lens technologies that you can use without bothering the trab can be very challenging as well. All right, so I'm going to welcome back Dr. Lee. Dr. Lee is going to be talking about her